We are shaking things up this week as we invite health leaders and healthcare journalists to dissect our top stories. Hometown Cerner topping the headlines as they snag a coveted multi-billion-dollar contract to overhaul the military's health records. Is the Affordable Care Act becoming unaffordable? Why area insurers are now seeking massive premium increases? And why a Kansas report says the state's mental health system is now so inadequate it's jeopardizing your safety. Welcome everyone, I'm Nick Haynes. Those stories and more coming up as we laser in on health news this half hour, and there's a slew of stories to talk about. We make sense of it all with four people who are following healthcare closely in our region. John Bluford led Truman Medical Center for 15 years. He's now president of the Bluford Healthcare Leadership Institute. Dan Margulies is editor of the Heartland Health Monitor, a reporter collaboration between KCUR, KCPT, Kansas Public Radio, and the KHI News Service in Topeka. It's there in the state capital. You'll find Jim McLean, who keeps tabs on all things health, as executive editor of the KHI News Service. And Brenda Sharp is CEO of the Reach Healthcare Foundation, the Kansas-side philanthropy focused on improving access and care to the medically underserved. You know, it was the story getting Kansas City more national attention this week than any other. So let's start there. Our metro's largest private employer, healthcare technology firm Cerner, awarded a more than $4 billion contract by the Pentagon to overhaul the military's electronic health records. That's 9.5 million service members and their families here and overseas, from Iraq to Afghanistan. Dan Margulies, if I don't work for Cerner and I don't serve in the military, why on earth should I care?
Well, you should care about the military, first of all. But secondly, just looking at it from a strictly parochial point of view, as you said, Cerner is one of the biggest employers here in Kansas City. They currently have about 20,000 employees, I think, worldwide with their merger with their acquisition of Siemens earlier this year. This is going to require them, this contract with the Pentagon, is going to require them to ramp up that employment even further. So in terms of just the economic impact on Kansas City, it's going to be huge.
So more jobs in Kansas City is going to come as a result of this, John Bluford?
Well, I would certainly think so, and it matters to the community as a whole, because those jobs mean economic development and purchasing of homes and automobiles and so forth in the area. So, and not only that, but it brings a very astute employee workforce to the area. So these are very highly competent people.
These are high-paying, high-perk jobs, right. High-benefit jobs.
Okay,
yes.
So one of the benefits of this also could be for Kansas City that now they'll have more money to bring an NHL team or an NBA team to Kansas City. Jim McLean.
You want me to talk about that?
Okay, no, all right.
Not.
Well, not all of us are affected by the Cerner deal, but most of us have a stake in our next headline.
The CARE Act is sounding less and less like it.
If you buy your own health insurance, you could see your prices skyrocket.
The results are in, and they are not good. Health insurance premiums are very likely going way up, not just a little bit up, but way up.
Is the Affordable Care Act not so affordable after all? Proposed double-digit price hikes for some health insurance plans in Kansas and Missouri are raising alarm bells about the Affordable Care Act as it enters its third year of enrollment. In Missouri, Coventry Healthcare is proposing rate increases of up to 29%. Blue Cross and Blue Shield of Kansas seeking increases of 37% for 2016. Why such a massive increase? Brenda Sharp.
Well, I think that what folks have realized in these insurance companies in particular is that there was a lot of pent-up demand for health insurance among a very sick population, and they had underestimated their exposure on premiums.
Jim.
Yes, just that, and this was predicted because the insurance companies literally had to bid on the business sight unseen. They didn't know the populations they were going to serve, and once the data started rolling in, exactly as Brenda said, it was a sicker population and a population that had not had health care for a long time, and so had a lot of needs. And they went to the doctor, they went to the emergency room, they went to the hospital, and they got those health care needs taken care of, and that's why we're seeing the increases. One quick thing to point out, though, the subsidies, the tax credits that you can get from the federal government to help make these premiums more affordable, bill will also go up with the premiums to keep those premiums affordable for people who qualify. And the vast majority of people who are buying these policies in both Kansas and Missouri are qualifying for those subsidies.
But will fewer people, though, now want to sign up for this?
Well, the operative word, too, is proposed, and these increases have not been put in place yet. So we need to wait a little while and see what happens.
The regulators can negotiate these prices down, and also there are a multiplicity of plans that people can choose from. So we're talking averages here, but you know, the benchmark plans, the silver plans, they can be a lot cheaper than these averages. And again, as John points out, these are only proposals. And what we'll see in the final analysis are rates that are not nearly as high as what people are brooding about right now.
Let's look at what's happening on the ground. A new report detailing the Metro's health is released this week by the Reach Foundation and the Mid-America Regional Council. 12.8% of metro area residents are still without health insurance. That's one of the findings. Is that higher, lower, or the same as it was before the Affordable Care Act?
Actually a little lower, and we've seen a dramatic impact of the Affordable Care Act and health insurance exchanges in Kansas and Missouri. Lots of people enrolling in our area. It might surprise some people to know, for instance, that in Johnson County, considered to be a very wealthy community, 25,000 people enrolled in the exchange in the most recent enrollment period. That's more than any other place in the state. As word of mouth gets out and people begin to understand that these are private plans, that they are good quality plans, there's an essential level of benefits that are included in these plans, I think we'll see an even greater uptake in outreach in enrollment period 3, which is coming up this fall and spring.
But we are seeing also headlines with more patients now getting coverage through the Affordable Care Act. That has done, what has that done to your ability to see a doctor? How long it takes you to get an appointment? A survey this year by the Physicians Foundation found 81% of doctors described themselves as either overextended or at full capacity. And an AP headline tells of patients flocking to emergency rooms in greater numbers. Are we experiencing that here, John Bluford?
There are increases, and you would expect that with people having coverage. But the answer is going to be in using physician extenders, whether they be nurse practitioners or physician assistants and other healthcare professionals. Pharmacists play a role in that. You'll see that happening. But I wouldn't be overly concerned about the emergency room utilization. That's been a pet peeve of mine because there are fixed costs to run an emergency room. It's a 24/7 operation whether they see a patient or not. So there are going to be costs involved in running that operation. And if people can access it, convenient to themselves, I say go for it.
Dan.
Well, you know, the emergency room the increase in usage of ERs is a function of a lot of things, and one of the principal reasons that we're seeing this is because there's a huge primary care physician shortage in this country, and that has to be rectified. And another reason is a lot of people who are newly insured are accustomed to using ERs, and what we've got to do is educate some of these people about the proper usage of it, and we need better coordination between primary care physicians and ERs in order to do this. And another reason is, you know, they're convenient. I mean, they're open after hours. They're open after work. You know, your doctor may not be available then. So there are any number of reasons why this is happening.
Jim.
Yeah, Dan covered it.
Okay. Well, 50 years ago this week, President Lyndon B. Johnson headed to our metro to sign legislation to create 2 landmark programs, Medicare and Medicaid. And where did the signing ceremony take place?
The Harry S. Truman Library at Independence, Missouri is the scene of an historic event. President and Mrs. Johnson and Vice President Humphrey arrive for ceremonies that will make the Medicare bill a part of Social Security coverage. Mr. Johnson chose to sign the bill here as a tribute to former President Truman. The former president campaigned for Medicare 20 years ago, but it took 2 decades for his proposal to become law. The new bill expands the 30-year-old Social Security program to provide hospital care, nursing home care, home nursing service, and outpatient treatment for those over 65. Medicare will become law on July 1st, 1966. And for Mr. Truman, an historic souvenir from the president.
Today, Medicare covers 55 million people, a number that keeps growing. While not mentioned in the video, President Johnson's signature at the Truman Library also gave birth to Medicaid to cover the poor. 50 years on, the debate is focused on expanding the program to more people. 31 states have loosened their income eligibility requirements to ensure more citizens get coverage. Kansas and Missouri aren't among them. There are now reports, though, that states that expanded coverage have seen enrollment grow faster than expected, leaving them with long-term funding concerns. So does that make it even less likely that Kansas and Missouri will move forward with Medicaid expansion, Jim?
Well, strictly speaking, in answer to your question, probably, but there wasn't a great deal of interest, particularly in Kansas, in doing it anyway. And frankly, Nick, there's research on the other side, too. There were 8 states that were studied. These were expansion states, and they saved collectively $1.8 billion in their budgets because they expanded Medicaid, because they saved on other programs, and because of the influx of federal dollars that then came into those states and created jobs. And so they're offsetting costs here, offsetting benefits, revenue benefits to the costs as well. Keep in mind, for the last 3 years, the federal government's been paying 100% of the expansion costs. That ratchets down ever so slowly to 95% and then eventually settles at 90% in perpetuity.
But I thought it was going to get out that the federal government would only be paying 10% by about 2020. Isn't that correct?
No, they'll still be paying 90%. They still have it reverse, yes.
Okay.
For the expansion population only.
That's correct.
So what we're actually seeing on the ground, though, Brenda, with regards to these individuals who are not in this coverage gap at this point in time?
Well, I think it's been a very frustrating year for advocates and people who understand that they need health coverage and have gone to sign up either on the healthcare.gov website to find that they're too poor to be eligible for subsidies and come back and look at their state Medicaid program and realize they're too rich because maybe they make more than $9,000 for a family of 4 in Kansas, for instance, and are ineligible for our state's Medicaid program. So I think what will change this conversation over time is the economic reality for states who have been implementing Medicaid expansion now for 2 to 3 years, and as my fellow panelists have alluded to, you're going to see an increase in healthcare jobs. You're going to see an increase in a huge decrease in uninsured rates and increase in just healthcare sector expenditures and revenues.
Yeah, the economic engine that some of these funds create in their local communities is just tremendous. In the states that have converted or expanded their Medicaid programs, the healthcare sector has grown significantly. That's jobs and high-paying jobs at that.
Okay. Well, Jim, before you speak, because you actually been chatting, I know, with patients who are right smack in the middle of this coverage gap. Right. Here's one patient you caught up with in Coffeyville in southeast Kansas. Can we see a little bit of that video?
Monty Campbell's Parkinson's disease cost him his job at a local refinery. His tremors got so bad he couldn't hold on to tools or even a phone.
I just want to check kind of what your symptoms are doing. Go ahead and put your hands on mine.
He's applied for disability, but in the meantime, he's got no coverage to help cover the cost of the medicines he needs.
You know, I've paid taxes all my life, and I've paid into the government. I've supported politicians. And now I just feel like I'm thrown out to the curb. Got to quit thinking dollars and cents and start thinking of human life.
But everything that John said, though, I mean, we see some of the factual information about what's happened in states that have expanded Medicaid, but you said earlier that there was still absolutely no signs at this point that that would actually happen.
In fact, Governor Brownback just last week said that he's still not particularly interested and that hospitals ought to look toward innovation because hospitals are in a real financial squeeze here, many of them, because there was kind of a deal. The Affordable Care Act was supposed to really significantly increase the number of privately insured, and it was supposed to increase those who had Medicaid coverage. In exchange, the hospitals agreed to some reductions in Medicare reimbursements. The hospitals in Kansas and Missouri and other providers are suffering the reductions, and they're not getting the offsetting benefits of the Medicaid expansion.
How about on the Missouri side, Dan?
Missouri side looks somewhat better, but not very much better. I mean, the Republican-dominated legislature has shown very little interest in expanding Medicaid in the state. And while we have a Democratic governor over there, Jay Nixon, who has expressed interest in doing so, he hasn't been able to persuade the legislature to come along.
Brenda.
Nick, I would argue that hospitals and our safety net community, the federally qualified health centers and community-based clinics are innovating. They've been innovating at a very rapid pace. They're implementing electronic health records, workflow models, patient-centered models of care, becoming medical homes and accountable care organizations. So I think this notion that they're not already innovating is a little false. I think they've been working very hard to keep up, but we need the public sector to be a partner in this effort effort as well.
In fact, when I was down in southeast Kansas, the hospital in Independence, which is very nearby, Coffeyville, it didn't shut down entirely, but it shut down its inpatient unit, its surgical unit, its acute care unit, and it's transferring all of that business over to Coffeyville. It's going to maintain its emergency room. And it was one of the hospitals that was really hit hard by the state's decision not to expand Medicaid.
John.
The hospital sector has been in the innovative mode for the last 5 to 10 years, but you cannot innovate $100 million of bad debt away. That's difficult to do. So as long as those hospitals have open access to anyone and everyone, regardless of their ability to pay, and those patients can't pay, and they start running up debts in the hundreds of millions of dollars for respective hospitals, it's hard to knock. What used to offset that debt was the disproportionate share payments that Jim spoke about, that the federal government has subsidized other hospitals over the years for indigent care. Those subsidies are going away with the Affordable Care Act.
One other quick thing to mention about Kansas, and one of the barriers is the state's budget situation. As you pointed out, there's a fear that if we expand Medicaid, the costs associated with it won't be sustainable, given the fact that our revenues continue to come in short of expectations.
So the nation is marking 50 years of Medicare and Medicaid this week. We're also marking 25 years of the Americans with Disabilities Act, signed into law 25 years ago this week.
I now lift my pen to sign this Americans with Disability Act and say, let the shameful wall of exclusion finally come tumbling down. God bless you all.
There was a letter in the Star this week from Kansas City disability advocate Susie Hake, who says the Americans with Disabilities Act represents the single most meaningful event of my entire life. She popped into the KCPT newsroom this week to tell us why.
I would not be able to use the MAX bus to come down to KCPT. I would be able to drive my van, but I wouldn't be able to find a parking place because there would be no accessible parking. There would be very few curb ramps for me to get up and around sidewalks. An employer could fire me just because I had a disability.
Just because you pass a law, though, doesn't mean everything is hunky-dory with the waving of a wand. We see that unemployment is stubbornly high among the disabled.
It's a mindset. When someone in a chair or someone who's blind or someone who is hearing impaired comes in for an interview, there's all these what we call attitudinal barriers that come up from the hiring manager. It's like, oh my gosh, what am I going to have to do to accommodate this person? And it's usually not much at all. It might be raising a desk. It might be some equipment on a computer so someone who is blind can read reports and read the computer. It's very, very minimal. Most changes are free.
As our Week in Review continues, the theater shooting in Louisiana has renewed the debate over gun laws in this country, but it has also prompted a slew of questions about how we care and treat the mentally ill. It's a local question, too, as a report released in Kansas this week concludes that the state's mental health system is so inadequate it's jeopardizing patients and the public. The report comes just weeks after a patient from Osawatomie State Mental Hospital beat to death another man 3 days after his release. The patient's father claims his son was discharged too early. The report finds there's been system-wide pressure to discharge patients quickly to make room for more. Missouri is facing its own problems. The St. Louis Post-Dispatch saying the state has cut more than half its psychiatric hospital beds since 1990. There's also no licensed psychiatrist in nearly half of Missouri's counties, and in some parts of the state, it can take up to 6 months to see a psychiatrist. But does this new shooting that relates to a mental illness and this new report from Kansas influence the increase of more money for mental funding in the state of Kansas, Jim McLean?
Well, it may create conversations about it, Nick, but as I mentioned before, there's an ongoing budget crisis in Kansas, and it really is, whether you're talking about mental health, Medicaid expansion, or lots of other issues, it really is policy by triage in Kansas, and the mental health system in the state is stressed. The notion was we want to get more people out into the community-based care and out of institutions. When mental health reform was passed decades ago, Now we have renovations going on at Osawatomie that were required by the federal inspectors, and that then has reduced the number of beds there. And it really is, they're just trying to move pieces around the chessboard to kind of keep that system functioning at all. It's very highly stressed in Kansas right now, and there may be a desire to talk about increased funding, but it would be a very tough conversation.
How did you see the issue of mental health playing out at Truman Medical Center? People think, oh, that's just happening somewhere else, but it plays out everywhere.
No, it's happening in this community, and those reductions in beds have meant a lot to this community in a negative way, because we have people with mental health disturbances and disease walking our streets today. It really gets to a quality of life and a safety issue in the long haul. We don't have enough capacity in this community for behavioral health.
So why is it that mental health is always such a hard nut to crack when it comes to funding, Brenda?
I think that many people kind of dissociate themselves from who they think of as a mentally ill person versus someone that's in their family or a friend that they've known. And until those two worlds collide, they don't really understand the desperate need for mental health services in our communities. Unfortunately, the model that we're using in both Kansas and Missouri to a little bit lesser extent is we're using jails and hospitals to treat people who have mental illness. In the state of Kansas, I don't understand why, but just this week declined to pursue an innovation grant with the federal government that would bring needed mental health dollars back to our state. Missouri is going to pursue that, and I'm very happy about that. But we have to, again, get back to where we have a partnership approach where the state government, the federal government, our local community, our philanthropies, our hospitals, our public safety systems are all working together. And right now, for some reason, our state government has not been a partner. They've cut state funding to mental health services in the state of Kansas by 50% since 2007.
Jim.
Yes, and keep in mind, too, a lot of private hospitals have shut down their psychiatric units, putting more pressure on the state hospitals. And again, those state hospitals are for people who are judged either a danger to themselves or others. And that's not true, of course, of all people who need mental health treatment. But in those extreme cases, such as the one you referenced, those are very, very absolutely needed facilities. And at this point, they're at maximum capacity.
There's a failure to appreciate that spending money on the front end will save a lot of money on the back end. And that is something that politicians who tend to think short term don't take into account. I mean, we're talking about, for instance, in the $63 million that the governor has moved around, his budget director yesterday in Kansas. We're talking about money that was going to be spent on Larned State Psychiatric Hospital.
They've delayed the opening of a building.
They're delaying the opening of a building to save some money.
The problem is longer than a 4-year problem. It's a generational issue. As I recall, many of the hospitals, not only in this community but around the country, with major emergency rooms, 40 to 55% of the patients that present themselves in emergency rooms have a comorbidity of either addictive behavior or mental health. It's a serious problem.
A widening epidemic of childhood obesity is taking a toll on the nation's armed forces. Now, a group of Kansas generals have issued a report detailing the scale of the issue in the Sunflower State, and it's alarming. 71% of those eligible for military service in Kansas are unfit for duty. And the main reason? They're too fat. Department of Defense figures say the situation is slightly worse in Missouri, where 72% of 17 to 24-year-olds are ineligible for military service. Now, Kansas raised the cigarette tax. Now that the military is concerned about this issue of obesity, might they consider a tax on soda or junk food, Jim?
No.
I mean, the military, the military is not viewed as a liberal bastion.
Absolutely not. But keep in mind, they may do that in the city of New York. You remember, you remember the soda tax there and proposals like that. I think there is a general concern, and we're going the wrong way when it comes to obesity in the state of Kansas. We're slipping in national rankings, so it's clearly a problem, not only in regard to this military issue, but it's a health problem because it leads to so many other things and expenses in all kinds of ways. But I mean, I don't think there's going to be a serious discussion in this state at this time on the kinds of proposals you...
Brenda Sharp, the Reach Foundation, joined with the Mid-American Regional Council in a health assessment of the entire metro this week. I referenced it earlier. Most of the healthcare indicators were going down. They were in better shape than they were before. But one of the sticking points, though, was obesity going up in the metropolitan area. Did you find out why that was?
No, I don't think we have the actual, kind of underlying causes, but I would say that some that are really being seriously looked at is increasing activity level among children and youth. And we have changed our school programming so dramatically over the last couple of decades. Most of us remember recess and sports for all, and lots of rec programs during the summer. And as budget cuts have taken away many of those programs, the schools are really struggling to find ways to keep kids active.
John, one of my favorite interviews with you during your time at Truman was when you came on and we were talking about the policy at Truman that was going to stop any employee from smoking on or off the job. And that was, you were at the forefront of that in Kansas City as an employer.
That was a good...
But absolutely. But is there any effort, among employers to say, look, let's look at issues of junk food and soda? I mean, if tobacco.
No question about it. Yeah, and I think consumerism will get a handle on this before the government does, because people are looking for healthier foods now, and hospitals all across the state and the country are really amping up their vending machines and providing more healthier foods in their retail cafeterias and so forth. So it's happening. It's just a generational process in my mind.
I would note that John's hospital used to have a fast food franchise on the premises, and I believe John was the one who said, no, we got to get rid of it. Am I correct about that?
That is a very big initiative.
Yeah. And there are things happening. The government, the Kansas Hospital Association has an initiative now where they're trying to increase the quality of the food in hospital cafeterias across the state. And even last year there was a suggestion that maybe we lower the sales tax on food for quote-unquote healthy foods, fresh foods and so on. So there is some talk about responding to this obesity crisis, but there isn't a talk on taxing soda or sugary drinks, that kind of thing.
I do want to point out, though, the report that you referenced, and what we're finding is that racial and ethnic disparities are continuing to persist. So as bad as the obesity epidemic is for the general population, for minorities in our communities, it's even worse. And what that translates to is early morbidity. People are dying sooner if they happen to be a person of color in Kansas or Missouri.
Okay. I don't want to end on that note, so what do we actually do about that, John?
Well, she speaks to one of my top peeves, and that's just the socioeconomic determinants of health, and it really speaks to some of the things that Brenda was talking about. And we really need to looking at jobs, educational attainment, housing factors, environments that these young people and their families live in before we really get a handle. We cannot resolve it at the hospital's front door. It must start to be fixed earlier.
And that is our whirlwind look at health here on this special edition of Week in Review. Our thanks to our news reviewers John Bluefoot and Jim McLean, Brenda Sharp and Dan Margulies. I'm Nick Haynes. From all of us here at KCPT, thanks for spending part of your weekend with us.